And good morning. I'm Dr. Kim Allen Williamson, Chair of Medicine here at University of Louisville, and it's definitely my pleasure and privilege this morning to introduce one of our major superstars and leaders here at this institution, Dr. Craig J. McClain, who is a professor in the Department of Medicine, Pharmacology, and Toxicology. He is our university's Associate Vice President for Translational Research and Associate Vice President for Health Affairs and Research and Director of our Clinical Trials Unit. He's the Director of our Louisville Alcohol Research Center, and he has been an amazing leader both here and at our VA, where he's the Director of Gastroenterology, and he is my co-division chief here in the Department of Medicine for the Division of Gastroenterology, with his specialty in liver disease. Dr. McClain will be speaking this morning on nutrition and chronic liver disease, but let me tell you a little bit about him. So Dr. McClain actually hails from Richmond, Indiana's Earlham College, and he went from getting his college degree there to University of Tennessee, and from there to Pitt, where he did internship and residency and fellowship in GI. He then started an amazing academic career at the Minneapolis VA and University of Minnesota, and transitioned ultimately to the University of Kentucky, where he made such a name for himself that he became Director of Gastroenterology and made it to Professor of Medicine. And ultimately, he was attracted to this place, which he then came and built an amazing institution of gastroenterology, hiring key people, who many of whom are still here. And his legacy is absolutely amazing. It's wonderful to hold a CV in my hand that has nearly 1,000 publications, more than that if you include all of the lectures as a scholar, a teacher, a researcher. And we're really proud to have you here, and we appreciate all of your leadership and all of your ongoing enhancement of our entire research enterprise. Thank you so much, Dr. McClain.
Thanks, Kim. And it's a real pleasure to be here today and talk about maybe my favorite topic in an area that I've worked in for over 40 years, which is nutrition and liver disease. And this is actually highly timely because we just finished the guidelines on nutrition and liver disease, Dr. Singhal and myself, and sent them in yesterday. And I'm glad to have that off my plate. Now, if you don't work in liver disease, you might wonder, is this grand round applicable to me? And it definitely is. So if you take care of patients at all, this grand rounds will be something that I think you'll learn something from. So our objectives in the next 50 minutes or so are to describe the prevalence and implications of malnutrition and liver disease, be able to assess, identify malnutrition, provide appropriate therapy, and then we're going to talk about, I think, some exciting novel things that we're doing here at UofL. I have nothing to disclose related to this talk. And like all of our grand rounds, we start with a patient. Some of the facts have been changed to keep her identity a secret. She's somebody well-known in town. So 69-year-old Hispanic female. She has early cirrhosis. Her husband died a couple of years ago. She's been drinking more than she should. She's not cooking anymore. Too much fast food, no exercise. Importantly, she has difficulty getting out of a chair. She lives alone in a very large house with a huge staircase coming down. And her son said, this is a death trap, brought her in and said, we need to fix things. So we'll talk about that. So what about prevalence and implications of malnutrition? Well, this was best studied actually in VA cooperative studies 30 or 40 years ago. And everything that we saw in people with alcohol-associated liver disease, we now know can apply to metabolic dysfunction-associated liver disease, PBC, and other types of cirrhosis. So once you get to cirrhosis, you're likely to be malnourished. So this is one of the early alcohol-associated liver disease studies done in our VA system. So it was done here with Dr. Tamburo. It was done with me in Lexington. And if you look at the yellow bar at the bottom, that's the best indice of malnutrition, the creatinine to height index. We don't do that anymore because you have to have an accurate 24-hour urine collection, which will never, ever happen in our current hospitals. But you should be 100%. So you can see even people with mild disease were only 75% of normal. Some of the other things that used to be used, like albumin, lymphocyte count, aren't good indices and are especially bad in people with liver disease, and we'll talk about that a little bit more. So again, from the early VA cooperative study, we came up with a malnutrition score. And so if you were 100%, you weren't malnourished at all. And then over at the left in the magenta there, if you were severely malnourished, you can see you had a 80 or 90% chance of dying. So these people all had basically the same bilirubin, the same severity of liver disease. The thing that distinguished them was malnutrition. Now, do these early studies relate to what's happening today? Well, on the right, you can see a very recent study showing exactly the same thing. Malnutrition directly relates to outcome in people with severe AH, and not only mortality, but infectious disease outcomes. And it also relates to transplantation outcomes, frailty, almost anything you can think of. We'll talk about individual macronutrients. So protein, carbohydrate, and fat. So protein is what we think about the most with malnutrition. And what we think about is sarcopenia. And this is one of my early VA cooperative patients. And you don't have to be a rocket scientist to figure out this guy's malnourished. This is what you do when you call it a subjective global assessment. You can see the sarcopenia that he has. And we know from our studies that these people were taking in under 60 grams of protein a day, and you have to be taking in at least 85 to be adequately nourished and in positive protein balance. Now, this is what we see today with sarcopenia. So here are guys laying on the couch. He probably can't get up out of the couch. He's got the remote there. But it's more difficult to see that he's sarcopenic. But this is called sarcopenic obesity. And Dr. McClain knows this very well. The bar diagram at the bottom shows muscle loss related to aging. And unfortunately, you start to have significant muscle loss by the time you're 45. So muscle loss starts early. And so you have to help prevent that. And most of our patients with cirrhosis are older, so they have a double hit. Now, this is a recent study following patients over time with MASH and looking at appendicular skeletal muscle mass. And in the top two are normal controls and people without significant fibrosis. And they're declining normally with age. In the red are people with MASH with fibrosis, not cirrhosis, just fibrosis. And so this is something that we found with MASH, that if you have fibrosis, basically all of your outcomes are worse. So for Dr. Williams, cardiovascular outcomes are worse if you have fibrosis than if you don't have fibrosis. Now, whether that's because they have more chronic inflammation or what, we don't know. What about carbohydrates? Well, I hate fructose. And so fructose is bad for you. And there are animal studies to show that. There are human studies to show that. And so this is a simple thing to do to modify your diet. Get sugared pop out of your diet. And this is a great study that's, again, recently been published, looking at greater than 98,000 postmenopausal women and looking at basically sugared pop. And so if you drink more than one sugared pop a day, your HCC mortality and liver mortality go up dramatically, as shown here. So, I mean, that's unbelievable. One a day. What about fat? Well, fat's kind of interesting because it depends on what kind of liver disease you have, on which type of fat is actually the worst for you. So for alcohol-related liver disease, which I started in, it's N6 polyunsaturated fats. So that's linoleic acid is a big one there. So that's corn oil. And so corn syrup is fructose, corn oil, linoleic acid, bomb Iowa, you get rid of all of this, okay? So N6 fats are particularly bad, and we have a bad N6 to N3 ratio, and we'll talk about that. And what happens, these N6 fats get metabolized to things called oxalams, and that's oxidized products of linoleic acid. And they're highly reactive, and they can cause inflammasome activation, disrupt the intestinal barrier function, cause mitochondrial dysfunction, and relate to many types of diseases, not only liver disease. Now, many of you, if you're old enough, have seen the movie Super Size Me. So for MASH, it's saturated fat. And the guy that was in this movie actually died this past year of pancreatic cancer. But we had a chief resident at the time, Ryan Hurt, that many of you would remember, who took this movie, and when they were looking at the guy's medical chart, he froze the frame and was able to pull off his medical record here. And you can see that 1 month of supersizing at McDonald's not only caused him to gain weight and caused his lipids to go up, but caused his liver enzymes to markedly go up. And that's why they told him, you got to stop this. Micronutrient deficiencies. So you can have, instead of global malnutrition, have isolated micronutrient deficiencies. And my favorite one is zinc deficiency, which is where I started my career. So the guy in the upper right-hand corner was one of my original patients when we were describing back in the 70s, the clinical manifestations of zinc deficiency. So that skin lesions that you see around the eyes, nose, and mouth are called acrodermatitis. And below is one of my rats with zinc deficiency, and you can see the same crusting skin lesions. And in our patients, we saw that people with cirrhosis had lower serum zinc levels. Those with cirrhosis and encephalopathy or PSE had even lower levels. And this was due to multiple factors, including poor intake, poor absorption, increased losses. Now, this is a very recent paper, and it looks at the dietary risk factors related to mortality and NAFL, or now called MAFL. And if you look here, this is probably something that everybody that's in nutrition, and I know Dr. Williams preaches. So here are the things that are low: fruits, vegetables, legumes, whole grains, blah, 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 blah. And then the things that were bad: red meat, processed meat, sugar-sweetened beverages, trans fatty acids. So all of these significantly correlated with the development of MASLD. So here's what applies to everybody. So how do we assess nutritional status? So there's a huge debate in the nutrition literature right now about body mass index. We should be using waist circumference instead. And actually for liver disease, both of these are problematic. So if you have somebody with edema, body mass index doesn't work, neither does waist circumference if they have ascites. The issue with waist circumference is it's not measured all the time. BMI is, and it varies depending on who's doing the measurement. So we don't have perfect anthropometry. And then there's some other things that dietitians typically use, like tricep skin folds and stuff. Again, if you have edema, that gets thrown off. Visceral proteins like albumin are really markers of inflammation and really not of malnutrition. Something that I like is the hand grip strength. So that can be done by a hand grip dynamometer, costs $100. You can have that in clinic. It's great to follow serially. I'll show you an example of that. Something I really love is bioelectric impedance. So we have a bioelectric impedance machine that we use clinically. We should have like 10 of these that we're using clinically. Ours is used, mainly research-wise. But this is an incredibly good tool, even in people with cirrhosis and ascites. And we'll talk about CT in a second too. So here's what your bioelectric impedance machine looks like. And so it's basically like stepping on scales. And it gives you a great readout of your muscle mass. It also tells you whether you're starting to accumulate extracellular water. So if you have somebody with cirrhosis or congestive heart failure that you think is picking up fluid, this will detect it before you can. Now, this is something that's written about a lot. This is one slice of a CT through L3 that they've got a computer program. And you can see on the left in red is the muscle mass. And on the right, you can see it's going down. And so this is a very accurate way of measuring muscle mass. Issue is somebody has to do it. But with AI now, there's absolutely no reason that every CT doesn't have this read and have it automatically shipped into Epic or Cerner. I mean, this is a low-hanging fruit for AI. And every cirrhotic gets one of these done every 6 months or a year. What about causes of malnutrition? Well, they're multifactorial. Anorexia is huge. So 60 or 70% of our patients have anorexia. A lot of them have delayed gastric emptying and nausea and vomiting. So Dr. Abel from our group has studied that. They all have dysbiosis. Lousy food quality, cytokine effects that I'll show you. And a biggie on the bottom, and again, this is why this talk applies to everybody, is our GLP-1 agonists. So when we talk about alcohol, people usually don't appreciate the magnitude of how much many of our patients drink. So on the left, I've got patients with alcohol use disorder with normal ALTs in a detox program. They're drinking 17 standard drinks a day. Now, I couldn't do that. I'd be in the bathroom all day. They are actually drinking more than our patients with severe alcohol-associated hepatitis shown below. And that's because they're starting to get sick and can't drink as much. This is way more than 1,000 empty calories a day. So alcohol doesn't have any fiber in it, doesn't have any zinc in it, doesn't have protein in it. And so this is why this is bad. On the right is shown what a standard drink is, which is 14 grams of alcohol. So I'm probably a bourbon guy over on the right. Dr. McClain's maybe a beer guy over on the left. So you need to know what each one of these looks like for a standard drink of 14 grams. 14 grams. So is you have to multiply 14 times 7 because each gram is 7 calories. And so you can see that each drink is going to be about 100 calories or more without a mixer. So this causes you to gain weight. Now, we said fructose is bad. And I have a favorite paper called Fructose, It's Alcohol Without the Buzz, because fructose is metabolized a little bit differently, actually very similar to alcohol. And again, my favorite drink, Mountain Dew. I have one of those a week out at the VA. 290 calories in that bottle. Again, not much fiber in here. Then an area that I've worked on all my life is cytokines and cytokine effects. And again, this is one of our patients from our VA cooperative studies. And you can see that many of the symptoms that these patients have and signs are directly related to cytokines like tumor necrosis factor and interleukin-1 that are elevated in these patients. So I can tell you, if I inject TNF into one of you, you will feel like you have the flu, you'll have low-grade fever, neutrophilia, won't want to eat. So many of the signs and symptoms that our patients have are related to cytokines. Now, why do our patients get sarcopenia? Well, I stole this from another article and just modified it and for cirrhosis, because basically our patients with liver disease have almost every reason you can think of to get sarcopenia. They tend to be older, they have low testosterone levels, they have anorexia, they're sitting around, they're not exercising. So everything that causes sarcopenia, our patients have. And now we have the GLP-1 agonists. And so this is kind of the untold story. It's coming out in the press. These are 2 recent articles on it by experts in the field. But as you lose weight with the GLP-1 agonists, you're going to also lose muscle mass. And they're trying to figure out combination drugs to prevent that. So that's a concern. But the bigger concern is if you see patients, insurance companies don't like to pay for GLP-1 agonists. And patients switch insurance companies. So there's this yo-yoing effect all the time. So I have patients come in and are saying to me, I lost 80 pounds and then I switched insurance company, or my insurance is not paying for it anymore. Now their weight goes back up, but they're not gaining muscle mass back. And so every time this happens, you're losing muscle mass and gaining fat back. And this is going to be a huge, huge problem for everybody seeing patients with obesity taking these drugs. What about nutrition support? Well, interest in nutrition and liver disease actually stems back to the 1940s. This article by Arthur Paytak. So he was in Columbia at the time and had a clinical research center. And so what he did, he went out and gathered a bunch of people that had alcohol-related liver disease. Back in the old days, they call it actually nutritional cirrhosis, and said, you know, come on into our clinical research center and we'll feed you 3 meals a day. We're going to try and get 120 grams of protein and 3,000 calories into you. And he showed that the patients who came into the clinical research center and did that had a much better overall mortality than ones that didn't, and historical controls. And then if you go to the VA cooperative study, so there, when we were looking at patients, we kept them in the hospital for a month. We could do that back in the old days. And so we correlated food intake. We had a dietitian assigned to these patients. And we just correlated voluntary food intake with 6-month mortality. And you can see voluntary food intake correlated directly in a stepwise fashion. So if you were eating 3,000 calories a day or more, why you weren't going to die. If you were eating less than 1,000 calories a day, your mortality was very high. There's a multi-center study from Spain where they randomized people to enteral nutritional support or steroids for alcohol-associated hepatitis. At 1 month, the data were the same. At the end of a year, the people who got enteral nutrition, TEN, had a better mortality than those who got steroids. And this may be some type of epigenetic effect of steroids predisposing people to infection. They tried to do a similar type study, again, a multi-center study in Europe, where people got steroids or steroids plus tube feeding. There, the improvement in mortality was only about 10% long-term and wasn't statistically significant. What they were very, very bad at was putting feeding tubes down, a lot of complications. But what they did show was no matter which group you're in, if you're taking in under 21 kilocalories per kilogram or under 77 grams of protein a day, you had an increase in mortality. What about special nutritional considerations? There's absolutely no evidence that tube feeding is going to precipitate GI bleeding in people with varices or knockoff bands that have been put down. Do not protein restrict for encephalopathy. So this is something that you still hear about. And so ammonia comes from protein, yes. But if you don't eat protein, your body just breaks it down. The ammonia is still there, so you need to give protein. And more isn't always better. So especially some of our individual nutrients can be toxic, like vitamin A. So our nutritional recommendations for inpatients with cirrhosis are evaluate them very early for electrolyte imbalance. So they could come in with severe hyperkalemia because they have renal dysfunction and they're on aldactone. They could have hyponatremia. Do early nutritional assessment. And then in red, we want to focus on protein. We want to get these guys enough protein. Now, what we're seeing frequently, those in the red at the bottom, are overweight patients. So if you come in with a BMI of 45 and MASLD, we're not trying to jam in high amounts of calories in that patient, but we do want high amounts of protein. So we do give a hypocaloric but high protein diet. What about outpatient therapy? Well, this is a study done in Japan, and they basically had physicians say, hey, eat a good diet, or they went to a dietitian, got counseling every 3 months. We're told about nighttime snacks, which we'll talk about in a second. Some of them were given branched chain amino acid supplements. And just that dietary counseling improved long-term mortality. Now, I mentioned nighttime snacks. So this is one of the things that we reinforce on all of our patients. And this is a wonderful study done by Planck and coworkers in Germany. And so they randomized people with cirrhosis to either a snack at 3 o'clock in the afternoon or 9 o'clock at night, and did very sophisticated body composition. And in the black, you can see the people who got the nighttime snack were able to keep on more fat-free mass or muscle mass. And that's because people with cirrhosis have an inability to store glycogen in their liver. So every night they go into a starvation mode and break muscle mass down. But if you have that snack at 9 o'clock at night, you don't do that. So every patient with MASH gets a lecture from me. This is back when we used to have in-person grand rounds in the auditorium. So need to look at portion size, no sugared pop, easiest thing to get rid of. No fast food, so that supersized me. No alcohol, exercise. So I'm old, but I can still get to the gym and use an elliptical or a recumbent bike. Can't run anymore. But if you do 75 minutes a week, why, that's good for your liver and good for everything else. We've had grand rounds before on coffee. Dr. Pfeiffer did one. And the target organ that shows the best results is the liver. I have a whole area in our guidelines related to coffee. So coffee prevents fatty liver, it prevents fibrosis, it prevents HCC. It's like a magic drug. And then for our people with early stage MASLD, we recommend vitamin E, 800 international units a day. So we'll talk about some fun things that are happening at UofL to end up grand rounds here. And so we have this Institute for Nutritional and Metabolic Therapeutics, and we're trying to develop new therapies to enhance the health and welfare of Kentuckians. And so we especially focus on the gut-liver-brain axis, and I'm going to focus on 4 things that we have exciting research on today, the top 4 things there. So the first one is zinc. So this is what I started with, and then a young guy, Matt Cade, you won't recognize Dr. Cade in that picture. So that's when he did this study, along with Dr. Zoe, who's now the directs the metabolomics unit at North Carolina. So zinc is an antioxidant. It has catalytic function and a whole bunch of zinc enzymes, and it induces metallothionein, which is a potent antioxidant. So we showed in animals that if you fed them alcohol in the blue bar, second blue bar, why they got fatty liver, liver injury. And if you gave them alcohol plus zinc over on the right, the ALT was less elevated. And much more prominently, you can see in the picture here that these animals here had much less fat than here. So it kept fat out of the liver. But we want to do stuff in humans. So he did a human study as part of his K award. And he randomized the cirrhotics to zinc or no zinc. And the ones that got zinc, their zinc level went up as you would expect. Their endotoxin level went down. And at the bottom, their Child-Pugh score went down. Butyrate is a short-chain fatty acid. So we did early studies in mice showing that mice fed alcohol had decreased short-chain fatty acids, altered bile acids, and altered branched-chain amino acids in the stool. Now, short-chain fatty acids are fermentation products of special bacteria, and you need that substrate, the fiber, to get fermented. And they can act through G protein coupled receptors, or they have epigenetic effects. They block HDACs. So shown here, we use a butyrate prodrug called tributrin. And we fed animals tributrin plus alcohol, and shown over here, here's the alcohol plus tributrin. So it attenuated liver injury. Now shown here is a heat map of the stool of patients with, on the right, alcohol-associated hepatitis, and on the left, normal controls of butyrate-producing bacteria. So the guys in the red, the alcohol-associated hepatitis, basically have no butyrate-producing bacteria. So they have a double whammy. They don't eat any fiber, and even if they did, they don't have the bacteria that will convert it. And so that's why giving this tributrin is so neat. What about polyunsaturated fatty acids? We mentioned the importance of the bad one, the N6, but the N3, the fish oils, are good. And so this cartoon shows the marked intake over time of total fat in the diet, but especially omega-6s are going up and omega-3s are going down. So Dr. Kerpick from our group had engineered mice that convert the N6s to the N3s. So you don't have to change the diet. You give them a crappy diet and the mouse converts it. And in doing that, if we just look at, let's say, liver enzymes down here, here's animals on the normal animals, and here are the transgenic animals that convert. And you can see the transgenic animals have higher levels of EPA and DHA in the lower N6 to N3 ratio. So this one enzyme basically prevents cardiovascular disease, prevents diabetes. It's amazing. So quite by accident, we started working with a guy at the NIH who was giving omega-3s to people with alcohol use disorder after they had been in the treatment program and were just ready to go home. So this is an amazing study here. So they're in the treatment program for 3 weeks. The day they go home, they get a spinal tap. They get treated for 12 weeks with omega-3 or a placebo, and they get another spinal tap, come back. So, and this guy knows nothing about liver enzymes. So we looked at the liver enzymes in these people, and in the red are the controls, and blue are the treated. And you can see the nice reduction in the blue. Now, the amazing thing is these guys stopped drinking. So these are heavy drinking days here. And this is increase in basically your omega-3s. And so there's a direct correlation between how much your good fats increased and your reduction in drinking. There's no drug on the market that comes close to this. The last thing I'll show you is probiotic therapy with Dr. Feng, who has now moved to Tulane. So he started using this one probiotic, Lactobacillus GG. It's one of the brand names is Culturelle. And to take 10 years of research is shown here. So he first showed that this worked in alcohol-fed mice, then MASLD mice, then mice with fibrosis. Then he showed you didn't have to give the live bacteria. You gave what the bacteria were producing and putting out in the supernatant. And then he showed what it was in the supernatant. It was bacterial exosomes. And now we have a provisional patent on that and hope to get rich on it. What we did do in a multi-center study with the NIH is give LGG to people with alcohol-related liver disease, moderate liver disease, and showed that they had an improvement in their MELD score, their AST to ALT ratio, but a marked reduction in their drinking compared to the controls. So in summary, we should be able to do nutritional assessment, provide nutrition support, and improve the health of our patients. And that's shown here on the right, long-term health. You can see this patient had a marked improvement in his muscle mass. Shown left is a hand grip dynamometer. Again, I love this. It's easy, it's quick, and it's great to follow over time. So in red is the MELD score going down. In the black is the hand grip strength going up. So this improves very quickly, actually, even before you put muscle mass on. So our take-home points are patients with alcohol-associated hepatitis and cirrhosis are frequently malnourished. Traditional nutritional support improves nutrition and may improve outcome. Nutritional therapy attenuates many of the mechanisms that cause liver disease, like barrier dysfunction. It's frequently overlooked, and we got really exciting therapies in the pipeline. So what about our patient? So what do we do? So no fast foods, no alcohol. We started her on a nighttime snack, started her on coffee. We got her out of that massive house into a massive condo instead. But it's one floor and it's got a gym. No rugs. People trip on rugs. She has a chef. She has meals delivered. Actually, she likes to cook now. She in the condo, she's got a lot more people around, so she's got friends, new activity, and she's doing daily exercises, including resistance exercises. So I hate resistance exercise. I'm on an elliptical, but you have to do it to keep your muscle mass up. Now, the most important thing, we have the liver symposium coming up. It's February 22nd, all day on a Friday. We're going to have Jason put this on the medicine website. Importantly, at the bottom there, it's free for anybody that's associated with UofL. And so you'll learn about all kinds of liver disease. So thank you, and I'll see if there's any questions.
Well, that's fantastic, comprehensive and so informative, with a lot of surprises of things that we just didn't know and hadn't heard of before. So, of course, my question has to be trying to do randomized trials for plaque regression here with nutrition and plant-based approaches, changing from an American diet. Couldn't we? I don't know that we've. I mean, you detailed all the things in the diet that would make things better. The question is, do you have any short-term biochemical or obviously long-term outcomes of a whole food plant-based intervention, randomized trial? We could do it for, several weeks with cooking classes to try to change people. Interested in doing that? And if we did do that, I mean, what would we really measure? One would be the ammonia level, because I'm thinking that if you're doing the kind of protein that has less sulfur.
Yeah, ammonia levels are terrible to deal with. So it's a good idea, but just from my practicality point of view. But looking at things like butyrate in the stool would be good. You could do fecal metabolomics. You could be doing urinary metabolomics, and doing studies like that are important. So I said we did these guidelines. So Steve McClain's here. He can tell you there's a huge difference between guidelines and guidance. So guidelines get graded. It's very, very complicated. You've got to have good studies. In the nutrition literature, there are very few good randomized studies. It took us 3 or 4 years to put these guidelines together. And so we just lack good studies. Most studies are retrospective correlation studies.
Yeah.
But
so we can do this?
I'll certainly talk to you about it.
Okay.
Yeah. What about the old saying that one glass of wine is good for your heart, but how bad that's for your liver?
Yeah. So and Kim's aware of this, there are the dietary guidelines. So the current dietary guidelines say that moderate drinking is 1 drink a day for women, 2 drinks a day for men, and that is theoretically safe. And there's this thing, the J-shaped curve with cardiovascular disease. I happen to think that that is still true. The Surgeon General says you shouldn't drink any alcohol because it causes cancer. Everything causes cancer. So the data for fructose is probably much stronger. So if you look at 3 million people, you're going to find stuff. So for people without liver disease, probably 1 glass of wine is safe. But if you have liver disease, we actually know from good studies that no alcohol is safe there. So I have a drink every night. I'm still alive. But I tell my patients with liver disease, no.
I would just add that we've retracted it. And that's the worst part about publishing guidelines is finding out something a couple years later that we were wrong. So our hypertension guidelines, prevention guidelines all had that, exactly what Craig said. There probably shouldn't have been much of a gender difference, and now we've retracted and saying 0 is best for the heart. All of that stuff was just not true. So the J-shaped curve probably was a phenomenon of people who were sick don't drink. So.
And it's the one thing that alcohol probably is clearly associated with early on with 1 drink or 2 drinks is cancer. I'm not sure that it maybe isn't a little protective with 1 drink a day, but hard to know for cardiovascular disease. But there is a clear push to go to no drinking, and it's an interesting political phenomenon that we shouldn't probably discuss at grand rounds.
The thing that's emerging in critical care nutrition right now is if you really want to build muscle or sustain what you got, we should measure testosterone levels and replete those levels. Are you seeing any of that in liver disease?
But clearly, testosterone levels are low in cirrhotics. And there is a study that giving testosterone can help improve muscle mass. It's actually not done very much, but the data are clear that it will help.
There's a couple of questions and a comment in the chat area. First question's from Dr. Emmons in Hematology. And he wanted to know, says, given that zinc can block copper absorption and copper deficiency can itself lead to liver damage, what is your practice for monitoring copper in patients with advanced liver disease for whom you recommend zinc supplementation?
Yeah, so this person knows too much.
That's a lot of stuff.
So absolutely phenomenal question. And so there's multiple levels to this. So the first one is zinc can block copper absorption in the intestine. And so that's why we use zinc to treat Wilson's disease, because it blocks copper absorption. But to do it really effectively, you need to take 220 milligrams of copper sulfate 3 times a day, fasting to do it. So you have to take fairly high doses. So we recommend under 50 milligrams of elemental zinc a day for our patients with liver disease. And that should not cause copper deficiency, and we don't monitor them. But on the other hand, we see people, and I didn't show these slides because of time, with MASLD who come in. So fructose screws up copper and iron metabolism. And it typically occurs in males, so it's a sex thing. It's the same thing in animals. So I see young guys coming in drinking 8 or 10 Mountain Dews a day, and their ceruloplasmin is 12, and their ferritin level is 750. And so one guy thinks they have hemochromatosis, the other guy thinks they have Wilson's disease. I think they're drinking too much Mountain Dew, and we stop the Mountain Dew and everything gets better. But I have had people, like I had a patient with Whipple's that had a Whipple procedure, and his copper went to almost 0, and he had terrible fatty liver disease, and we supplemented him with copper, and the fatty liver disease got better. So copper deficiency basically can cause the metabolic syndrome. So hyperlipidemia, hypertension, fatty liver, and you can accelerate that by giving fructose with it. So long answer to a short but great question.
A question actually from Dr. Kruger said, would other antioxidant and mitochondria improving supplements also be helpful? Is it SAMe, MitoQ, or turmeric, etc.?
Yeah, so we're looking at some other things that enhance mitochondrial function. So there's a guy, Dr. Jala, that has a thing called urolithin. So again, that's pomegranate juice gets converted by your gut bacteria to urolithin, which is great for aging and great for mitochondrial function. So there are several mitochondrial enhancers out there that we're looking at.
Kind of more of a comment from Dr. Dryden. He says there is also good data about the effect of 1 glass of alcohol on white gray matter ratio. 1 is enough to cause significant deterioration.
Yeah, so again, not enough really good data on that.
You want your one drink.
Or if there is, my 1 drink a day is preventing me from the number.
Yeah. And we'll close out with this one more from Dr. Emmons. He says, can you speak to the immunodynamics of aging and relative inflammation and its impact on the advancement of liver disease? Are the metabolomics directly causing liver damage, or are these indirect effects through immune system changes?
Yeah, so I'm not sure I can answer that in one sentence, but the answer is there's a huge interaction between the gut, liver, brain axis and inflammation. So there's a huge amount of data out there that neuroinflammation obviously is critically involved in Alzheimer's and in cognitive decline in people with too much alcohol intake. And so we're actually looking at that. There's a guy in our group, Sharish Barve, that does most of his imaging stuff, neuroimaging at Norton's, but we're looking at nutritional supplements for patients with Alzheimer's disease, but that's a incredibly important issue.
And that's all from the
Okay.